Hi, everyone. Good evening. I can't beat Dr. Mawela's nice picture of his the ocean at the back, and I'm sure it doesn't look like that in Nelspruit, but let's imagine it's like I have a boring theme wall behind me. So thank you for the opportunity. I'm honored to be asked. The topic we're going to discuss is important, but it's a very big topic. So unfortunately, I'm just going to skim over a lot of the stuff. I think at a later stage, we can maybe focus more in detail on the different aspects. But today's talk mainly will be just an overview of the main stuff that we see and that you guys probably will also see. So I'm going to try and share my screen. Not so technically savvy, but I think it'll work. Yeah, here we go. Can you see the screen?
Yes, it's clear. Thank you.
Yes, it's clear.
On full screen.
Here we go.
Thank you.
Yes. And I think we may, Dr. De Villiers, you may switch off your video for now during the presentation so that we don't have to use a lot of data for those who have slow internet.
Sure. Okay, good. I just need to make sure on my screen specifically, I've got a toolbar on the top. You guys don't see that. You just see my slide.
Yes, we only see your slides fully and nicely. Thank you.
Thank you.
Okay. So I'm going to list a few topics that we see often and that I'm sure you'll also see in with the hospitals that you work at. Intussusception is probably one of the most important ones and the ones that you will see most commonly. Mid-gut volvulus, extremely important that's picked up, and then gastric schisis specifically. So we don't really, in pediatric surgery, have many dire emergencies. A lot of the stuff can wait until the morning. Small bowel atresia or Hirschsprung's disease, something like that. It's not something that needs to be sorted out immediately. But these three topics that I mentioned now, the first three, are very important, and that is usually those are the three real emergencies that we see in pediatric surgery. Anorectal malformations also important. If you don't have an anus, it is a problem, and we do all need an anus. Meckel's diverticulum, appendicitis. I've seen appendicitis in newborns. It's possible. It can be anything from the first day of life until you're 80 years of age. I'm not going to discuss appendicitis now. Again, we can discuss this at another time. Pyloric stenosis is also something we see, not really in the newborn period, but after about 6 to 8 weeks. And then diaphragmatic hernias. I'll just quickly touch on that as well. So intussusception. It's an invagination of one part of the intestine into another. So almost like a telescope, the one part going into the other. Or if some of you might remember, we used to get toys. It's like almost like a small tubular balloon that kind of slips through your hand. So the top part goes into the bottom part. So that's basically what happens. It's really the second most common cause of acute abdominal pain in infants and preschool children after constipation. And again, constipation is a whole topic on its own that I hope you'll also have time to discuss at some point, but not tonight. Intussusception is most common from about 3 months to 3 years of age. In the first 3 months of life, as most of you know, the kids get the immunity from the moms. And then after that, they start building up their own immunity. So as soon as the immune response starts reacting and starts building up, that's the time that intussusception starts happening, because it's usually healthy kids. It's healthy, chubby kids. They are extremely difficult to drip because they've got a lot of fat. The scrawny, chronically ill kids don't really get intussusception. So they need to be able to launch a good inflammatory response, because the main cause of intussusception usually is a leak point from lymphoid tissue, from the Peyer's plaques that are sitting in the distal ileum. If you get a child with intussusception after 3 years of age, you need to go and look for pathologic leak point, and I'll also mention that. It's seasonal, like a lot of stuff we see for some odd reason. We don't really know, but it seems to be correlating maybe with respiratory tract infections or with gastrointestinal infections like diarrhea. It's usually ileocolic, and some of them actually reduce spontaneously. They go in and out and in and out. And those ones we don't they don't need surgery, but you obviously need to observe them. So you might see it now and then it's gone again when they look with the ultrasound again. And like I said, it's hyperplasia of the lymphoid tissue in the Peyer's patches, and most of them are located in the distal ileum. Then when we look at the pathologic lead points, tumors, we've seen kids with lymphoma and leukemias that present with an intersusception because of the enlarged lymph nodes. Polyps also, and a Meckel's diverticulum. I most recently had a newborn child that had a bowel obstruction. It turned out to be a Meckel's that caused an intersusception, so that was quite interesting. Now, if you look at this picture on top, I do hope you see my cursor that I'm writing here. It's a very unhappy child, but it's a nice, fat, chubby child. Again, that your heart sinks when you see these kids because you know you're going to struggle to get up a drip. If you look at the diagram here at the bottom, you can see the normal one in the middle. You get the ileum and the colon, and the ileum invaginates into the colon. And then on the right-hand side, the nappy, the ones that we often see, the bloody mucoid stools, or the red currant jelly. We don't really have red currant jelly jam in South Africa. It's more an American thing. But that's basically how it looks. Now, the reason for that is, as the obstruction happens, if you look at the bottom diagram here, the piece of intestine that's stuck there, eventually it becomes ischemic, it swells up more, it becomes edematous, it becomes more ischemic, more edematous, and then the epithelial lining of the gut starts sloughing off. And then you get microscopic, or not microscopic, you start getting bleeding. The distal bowel often has stool in it still, so they might still be passing stool until that bowel is empty. But then the rest of the colon still produces mucus, and also around the irritated area, the mucus production is more, together with the sloughing of the epithelial lining, and that's where the bloody mucoid stools come from. Sometimes the intersusceptum can go so far that it actually prolapses out of the anus. So it doesn't necessarily mean it's a polyp or rectal prolapse. You need to then also think of intersusception. They have abdominal pain and they vomit. They've got a typical picture of intestinal obstruction, a palpable mass. You can sometimes even on the PR feel the mass, like I said, if it goes all the way down into the rectum, and rectal bleeding and the bloody mucoid stools. You don't need a lot of investigations. First, you'll suspect it on the clinical grounds when you examine the child, when you get the history from the mom. Often they would say the child had diarrhea or a little bit of a runny nose or cough a couple of days earlier, and then the abdominal pain started. So it's really a complication of a medical problem, a surgical complication of a medical problem. Special investigations, just a simple abdominal X-ray, and you'll see distended loops of bowel. I'll show you a picture now as well. And then your ultimate diagnosis, if you still doubt, you can make on an ultrasound. Then treatment is pneumatic or hydrostatic reduction and or laparotomy, and I'll talk about that as well. Now, if you look at this picture, this was a picture taken intra-op. On the right-hand side of the screen is the head of the child, well, a bit further up, obviously, and at the bottom are the legs. The one part that I'm holding here, or that the assistant is holding, is the colon, and then you can see the small bowel that invaginates into it. This has already been partially reduced because you can see the appendix, but often everything is pulled in there. And sometimes it can be so severe that it even starts pulling in the stomach and the omentum, and it can be quite a mess to figure out what's going on. If you're lucky in this case, you might be able to reduce it without doing a resection. But often it's not the case if you end up doing a laparotomy, and then they end up with a right hemicolectomy. You take the distal ileum, and usually up until the transverse colon, you have to reset that whole area. So they do lose their ileocecal valves. Here, the X-ray you can see on the right-hand side is a typical picture of an intestinal obstruction. You see dilated, unhappy loops of small bowel. You can see the white lining that's there, the thickened abdominal wall, that's that white lining that we're seeing, and little or no distal air. You might still see a few blocks of air distally, but usually If it's advanced, you don't see anything. And on the right-hand side is the ultrasound picture. That's a transverse section, and you can imagine those different pieces of intestine that invaginated, the one piece invaginating into the other. So that's a bullseye sign that they see. Now, these pictures that you see now is the pneumatic reduction. So when they come in, if you've got a nice, friendly radiologist, you can ask them, please do a contrast enema, because often they can reduce it with a contrast enema. They've got the weight of the fluid as well as a little bit of air that they push in, and they also do it under screening. When we do a pneumatic reduction, we inflate or push in more air under more pressure. Preferably, this needs to be done when the child is at least sedated with ketamine, but it's best to try and do this in theatre under a GA, because if you do encounter problems, you can address it immediately. And also, I wouldn't like it if somebody blows air into me and I'm awake. I think it might be quite uncomfortable. Okay, so what we do is we take a Foley's catheter, a nice big one, like a 14 or 16 French. You push it inside the rectum and you get somebody to close the butt cheeks around it, the muscles itself, that you want to close the anus, otherwise all your air is just going to blow out. And then we use the old-fashioned BP cuffs or the BP meters. It's not really the cuff itself, so it's that little bulb, that plastic bulb that you inflate the BP cuff with. We use that bulb and the tube that's connected to it, and we connect it to the Foley's catheter with a syringe that we kind of fashion to fit in, and then we insufflate air under screening. We insufflate until about, usually about 100 millimeters of mercury or the systolic blood pressure of the child. And we screen. So if you look on the on the right-hand side of the screen, you can see a shadow that's sitting there. So the air is blown in all the way up, and then you start seeing the interstice septum, the shadow. And you insufflate the air while you are screening, and you watch that shadow. Hopefully it goes down and down, and it goes more down until it eventually, if you look on the picture here on the left-hand side, it's all the way into the cecum, and then it pops out and it's reduced. The way you know it's reduced is you see air going into the small bowel. You don't always see that, but you can't see it, unfortunately, on this picture, you can't see it well. But under real-time screening, you often see a little bit of air popping in. And then you know it's reduced. Then you don't have to do surgery. If you, in the process of trying to reduce it, if you insufflate too much air or it is just really stuck, it's not going to go anywhere, there is a risk that you might perforate the bowel. They will have acute distension of the abdomen, and the way to handle that is literally to take a gel cone and just pop it into the abdomen to deflate. And then, like I say, if you're in theatre, then you can do a laparotomy. So this you can do as many times as you need to do it. You reduce, it maybe 12 hours or 24 hours later, it recurs again. You can take them back and you can do a pneumatic reduction again. Again, if it recurs again after a couple of hours, you can do it again. And then after a while, this won't happen anymore, or otherwise you might end up that you have to go to surgery because you can't reduce it anymore. Usually it's about 24 hours that you have time to do this, or that it might recur again. After 24 hours, most often it won't recur again. Okay, so moving on to the next one, malrotation and volvulus. I usually explain to parents when I need to explain this to them. I often also write stuff down for them, and I tell them, go and Google, because if you can read up, you can look at diagrams, but just don't go and look at videos if you're squeamish. Just go onto Wikipedia, most of the stuff I Googled, to explain to them. But I would tell them the intestines are on the outside of the body when the baby forms, and then it has to twist and turn in a specific way as it goes back, and then the skin closes. And if there is a problem with that going back, if it lies in an abnormal position, you can have different issues relating to that. But the main issue, the biggest one, is a volvulus. So a malrotation in itself is not necessarily a problem. A malrotation, they can have intermittent vomiting, maybe a partial bowel obstruction, but the problem comes in if they have a volvulus. So with a complete malrotation, your bowel is very loose, the mesentery is not fixed as it's supposed to be, and the whole midgut is loose, and it can twist around itself. It's an acute presentation. Your baby would be fine, or even an older child. They are fine. All of a sudden, they have abdominal distension. It's tender, and they have bilious vomiting. And we always say, if you have bilious vomiting, it's an obstruction until proven otherwise. Now, if you have bilious vomiting with an acute onset abdominal distension, you have to think of a malrotation, because you have limited time in fixing this. If you're not in time, this is how it looks. This is now an older picture, but it's the best way to describe it. All of this bowel is dead. They can lose all of the midgut. So it's from this third part of the duodenum until the mid-transverse colon. And that's not really compatible with life. If you catch it in time, you can take them to theater, you do a laparotomy, you untwist it, and hopefully the bowel can perfuse again. But if you're sitting with a situation like this, it's really dire and there's not much we can do. To make the diagnosis of a malrotation, we do an upper GI contrast study. You're not going to do a contrast study if you're suspecting acute volvulus. Then you just take the child to theater. But if it's a malrotation, we do a contrast study, and you see this typical corkscrew sign. So if you imagine again the bowel that's twisted around itself, the contrast goes into the stomach, it flows into the small bowel, and it twists. It looks like a corkscrew. Then there's a volvulus. This child is not sick. He just has a volvulus, or a malrotation with a volvulus, but it's not something acute that's causing ischemia. It's like having a X-ray of a tension pneumothorax. You shouldn't have an X-ray of a tension pneumothorax because you should have relieved it before. So it's the same story with a malrotation and the volvulus. We also look for the position of the DJ junction. If it's sitting to the right side of the spine, we also know that there's a malrotation. Okay, the next one, gastroschisis. People often get a fright when they see a gastroschisis and they just don't know what to do. The important thing is you need to distinguish between a gastroschisis and an omphalocele. An omphalocele is not an emergency. A gastroschisis is. Gastroschisis is the bowel is on the outside, it's lying loose, but it can be covered with a thin membrane. So people can think, oh, this is actually a membrane, but it's not. An omphalocele has a nice membrane around it. It's like a blob that's sitting on top of the baby. Gastroschisis often has a small defect. And recently, some of you might know about the child that was transferred from Mpumalanga with a gastroschisis. The child unfortunately died. The defect was very, very small, so it constricted the bowel. So if you find a child with a small, small defect and it looks as if it's constricting the bowel, you probably will not do more harm by trying to enlarge the incision. And the way to do that would be to, in the midline, you just make a cut and you cut the skin and the subcutaneous tissue just to make the hole a little bit bigger. And that would actually buy time, and then it might actually even save the bowel. Okay, some other aspects, it's lying to the right of the umbilicus. You can see the umbilical cord lying to the left here. It has no sac. Often the babies are premature, and you don't really have associated defects like you have with an omphalocele. You can have some intestinal atresias, usually colonic atresia, undescended testes because of the mechanism, the mechanics of the testes, it just wasn't pushed down into the canal. And they can have reflux, but it's not really associated. You don't really have to worry about associated defects. Like I say, gastroschisis, the management of gastroschisis is really a topic on itself, but important thing is you need to cover the bowel. Anything, even if you don't have anything to cover the baby with, put him in a plastic bag. Obviously not the child's face, but I mean up to the chest. Take a Checkers bag, put everything in it and just close around it. It can keep it warm. If you have cling wrap, glad wrap, you put it around. If you're lucky, you might have a silo bag like you can see here. So the silo bag, they're quite expensive. They're about 3,500 to 4,000 rand. So it's not readily available. But it has a little spring, if you want to call it that, at the bottom. So it's like a big condom almost. The bowel is put inside of it. Then it's squeezed into the abdominal cavity, and that spring expands under the skin. So you have it anchored there, and then we can gradually reduce the bowel. But in the periphery, you probably won't have those bags. You can take a normal vacuolator a liter bag, a 500 ml bag, it doesn't matter. Cut the bottom of the bag off, just fold the edges around that it's not sharp. Place the bowel in there and you put some opsides on the side just to keep it in place. Nasogastric tube is very important. We want to deflate the stomach. You'll often see that the stomach is very distended. If you put an NG tube in and you aspirate on it, the stomach deflates. And fluid. These babies lose a lot of fluid. So we don't go for the normal recommendation of fluid for newborns. We jump to 150 mils per kilogram per day. We start with that volume, and then that actually compensates for all the losses because they lose a lot of fluid. The babies, often when they get to us, the big problem is not really whether the bowel was covered adequately or correctly or not. It's really that they haven't received enough fluid. 5% dextrose water, saline, Newlight, anything as long as there's some dextrose in it. Whatever you have available, put that up and give the child a good infusion. So when they arrive with us, we usually put up a central line. You can see the white tube that's here on the right-hand side of the baby's chest. That's a Broviac or a CVP or a PIC line, a peripherally inserted central catheter. We put up central lines because we know they will need long-term intravenous therapy and TPN, and then we gradually reduce the bowel over the course of a couple of days. Sometimes we're lucky and we can reduce it immediately if the babies were born with us, but often it's not the case. Even if the child is born in our hospital, we sometimes can't reduce it primarily. Okay, so here's a picture of an omphalocele. So you can see the obvious difference. There's a thick membrane around it. Umbilical cord is at the center of the defect. This membrane, though, can sometimes be very thin, so you can see bowel loops underneath. So be very careful when you clamp the umbilical cord that you don't clamp it with the normal plastic clamps that we use, because that can tear the sac, and then you make an omphalocele, a gastroschisis. Then it's an emergency. You suture ligate it, take a silk, a 1 or 2 silk, and just suture ligate that cord. And then the management of that is really simple. It depends on how big the omphalocele is. If it's a very small defect, we can often repair it primarily. We take the child to theatre, we repair the defect. But if it's a big omphalocele, we leave it. And we dress it with just normal. You can put Gelinet on it, Bactic grass, Adaptic, anything like that. Or you can do betadine dressings even if you don't have anything else. And the skin literally grows over this over time. It usually takes a couple of weeks, and then the child sits with a ventral hernia that we fix when they're a little bit bigger, around about 9 months to a year. So for the emergency care for these babies, you just cover it with Gelinet. You can either put a cray bandage, put some gauze over it, and then a cray bandage around the baby. Obviously not too tight because you don't want to constrict blood flow. And that is it for the management. But they have associated defects. They're often syndromic babies. They often have cardiac defects that can be said. They can have severe cardiac defects. They have renal problems. So the whole vectoral spectrum again that we look at, the vertebral, anal, cardiac, tracheoesophageal, renal, limbs. So you need to look at all of that. So the big issue with them is the associated problems. Now, an inguinal hernia, and again, it's something that is extremely easy to diagnose, but it's extremely easy to miss in neonates. If an inguinal hernia, if the intestine is strangulated, this kid can potentially die from this. So it's important to diagnose it. If you can pick it up early, you can sometimes even, you'll be able to reduce the hernia. Then you make an emergency situation an urgent situation. The rule we have is with inguinal hernias, under ideal circumstances, obviously, as soon as you diagnose an inguinal hernia, it needs to be fixed on the first available elective list. If it's incarcerated or strangulated and you can't reduce it, then it becomes an emergency situation. Unfortunately, we don't have that luxury in government. We can't always take them to theatre immediately. So we explain to the parents what to look out for if it gets incarcerated or strangulated or whatever, that they need to go to a hospital quickly. If you look at this baby on the left-hand side, you can clearly see there's something sitting in that groin. It's red, it's inflamed, the abdomen is distended. If you look at the x-ray on the right-hand side, you'll see distended loops of small bowel. So this child already has obstruction from this. So this is an emergency. If you can reduce it, it's nice, but often if it's already strangulated or even necrotic, you're usually not able to reduce an inguinal hernia. So that's also an indication of this child really needs urgent surgery. And this is something that should not be missed. Okay, just to go into a little bit of the theory again, it's a patent processus vaginalis. The canal usually closes around about 35 weeks of gestation. So that's why we find that the incidence is higher in premature babies. But then any child can have it, whether they're premature or not. Sometimes it's a familial thing. Sometimes a dad had it or a mom had it. You'll find that 10% of them are bilateral. So if you do have the facility available, if it's not an emergency situation, you do an ultrasound to check if it's not on both sides. If it's a girl, you can tell the parents, we can just go and open the other side and see if there's a hernia. But in a boy, you don't want to just go and open the other side because there are structures that you can damage. So you don't want to go and damage the blood supply to the testes and there wasn't a hernia on that side. So it's nice to know beforehand if there is one or not. And then boys, again, are having more often than females. It just seems that men are sometimes just giving more problems than females. Right, I'm just joking, by the way. Right side more than on the left side. And age at repair, like I said, as soon as it is diagnosed, and then if it's diagnosed in premature babies while they are in hospital, it's good to fix it before they leave the hospital, because often with the premature babies it's not picked up because they're small, there's lots of fat there and sometimes it's missed. So it's good to fix it before they leave the hospital. As soon as they're ready to go home, you can fix the hernia. Now I'm just going to quickly go over neonatal bowel obstruction and the different atresias. If you look at this picture on the right-hand side, it's a picture of a Hirschsprung's disease, but you can clearly see there's something wrong. Very dilated loops of bowel, a lot of gas, a lot of air in the bowel, and very little air that's sitting in the rectum at the bottom. So if you look at your x-ray, you can get an indication of where the obstruction is sitting. I'll show you another couple of x-rays as well. You can basically get an atresia from anywhere from the mouth up till the anus. Esophagus, the duodenum, small bowel, meconium plugs, and that can cause a distal colon obstruction, Hirschsprung's disease, and then an imperforate anus. Duodenal atresia, the double bubble sign. Again, you have your atresia. There's whatever the atresia is here at the bottom, there are different types, but that's not so important. The double bubble comes from the stomach dilates with air, and then the duodenum dilates with air. So that's why you get the double bubble, the stomach bubble on top and the duodenal bubble on the left at the bottom. These kids would have an NG tubing, they would vomit, and they'll have bowel. They'll be vomiting bowel. So then you'll know, again, it's intestinal obstruction until proven otherwise. They usually don't have a lot of abdominal distension because the obstruction is proximal. The more distal the obstruction, the more distended the abdomen would be. Jejunal-ileal atresias. If you look here on the left-hand side, you can see the different types. That is really just if you're really interested in how the different types look. But in the end, the management is the same and the diagnosis is the same. So depending on how far down the atresia is, again, would show you the amount of air that is there. On this picture, the X-ray picture on the right-hand side, you can again see these loops are very, very dilated. This is not normal, and there's almost no distal air. So this is a more proximal jejunal atresia. The more air you see, like I said, the more distal the obstruction. So just back to this quickly before we go on. The management of this would be you put in an NG tube, you deflate the proximal bowel, you put up IV fluids, and you consult your ped surgeon for surgery. They usually don't perforate, but if you leave it for long enough and you keep on feeding the babies, then they might perforate. Okay, an imperforate anus. Now, it seems simple, and it seems people would often say, how can this be missed? But it can be missed. Kids are sent home without an anus and nobody picked it up. Sometimes it's even the child of physicians. We had a child that both of the parents were physicians and they even didn't see it. It's obvious if it looks like this picture that I have up here. You can clearly see there's no anus. But sometimes the buttocks is nicely formed. There might even be a dimple. But you need to put something in to make sure the anus is open. So you can take a feeding tube or whatever you have available, the tip of a gel coat, the plastic cover, the outside cover, just make sure that the anus is patent. They also have associated defects. So again, the ones that will kill the child are is the cardiac anomalies and also the renal abnormalities. Those are the ones that can be fatal, and it needs to be picked up. The rest of the stuff is something you need to look out for, and that we usually screen the kids for. The most common one in a girl is a vestibular fistula. People would often say this is a rectovaginal fistula, but it's not. If you look on this picture, the vagina is there. You can see the mucosa prolapsing. The urethra is a little bit more anterior. And the fistula is sitting at the back. It's in the vestibulum of the perineum of the genitalia, but it's not in the vagina. So this is the most common one. And this one is often missed because the babies they pass stools, and then they often only present with signs of obstruction at about 6 months, 7 months of age, when they start going on solids and when the stool starts to get more formed, then they start obstructing. If you look at the diagram here on the right-hand side, you can see here the rectum comes down. It just did not make it to the spot it had to make inside the muscle complex. If we pick this up in the neonatal period, we can do a primary repair. We call it a PSOP. It's a posterior sagittal anorectoplasty. And that can be done in the neonatal period. If it's picked up later, it's often better to do a colostomy first, because then we just struggle with breakdown of the wounds if it's done in the child 6 months, if you do a primary repair. Now with a girl, you can get different types. The rectum can basically end anywhere it wants. If you look at these two diagrams on top. Here is a rectovaginal fistula, like I said, but this one is really very, very rare. It's probably less than 1% of the cases. And the most severe form in girls is this one in the right bottom corner. It's a cloaca. If you only see one opening, then it's a cloaca. And then it's really unfortunate. If I see a girl with a cloaca, a persistent cloaca, I would tell the parents, we are going to get to know each other very well, because it involves lots of surgeries over months and years to correct this. And we often see the babies regularly. I apologize about the quality of these pictures, but if you look on top here, sometimes you can see some meconium. This is now a boy, obviously. You can have a blob of meconium on the scrotum. Sometimes you can see some meconium that's lying somewhere on the perineum, and that would be, it depends on where the fistal ends. You get different types. It can be low, it can be high, you can have a completely flat buttocks. And it depends on where the rectum ends, what the prognosis of this child would be. But if it's a boy with an imperforate anus, they often obstruct quite easily or quite soon. So they need to come to us urgently. If they're older than 3 days, then it's usually problems because they're very distended, and they sometimes even have a bowel perforation by the time they arrive. So again, you need to diagnose it. You put in a nasogastric tube, you keep them fasted, and you put up an IV line with fluids. A Meckel's diverticulum, I'm just going to quickly run over this as well. It's the most common vitelline duct abnormality of omphallomesenteric duct or yolk stalk, whatever you want to call it. It's a true diverticulum because it consists of all the layers of the intestinal wall. It's usually within 90 centimeters of the ileocecal valve, and the problem comes in with the heterotopic tissue that's there, and it's usually gastric mucosa. It's unopposed or secretion of gastric acid, and that can cause either a peptic ulcer, or it can cause a perforation, and that's usually how they present. Here you can see it's a nice picture of a Meckel's. It's a nice bulb that's sitting there. This one was just an incidental finding on a laparotomy. You can see it's not really complicated. The rule of twos, unfortunately, this is again an American thing. So it's 2 feet from the ileocecal valve, 2 inches long, 2% of the population. Again, twice as common in males as females, and they're often symptomatic by 2 years of age. So you'll find that the parents would come in and they would say, my child had rectal bleeding, and it was a massive amount of blood, but the kid's running around like nothing's wrong. So then you have to suspect a Meckel's. I just love this diagram. It's somebody really sat for hours to draw this picture, but it's just really to explain again how it develops, how the yolk sac develops. Now, Meckel's can have different problems. It can look differently, the vitelline duct, and it can present in different ways as well. Okay, so they can present with bleeding, obstruction, inflammation, and it all depends on either the age of the child or whatever the complication is. Okay, I'm just going to run through this now. Like I said, the bleeding is usually painless. It's episodic and it can sometimes be quite massive, but then it stops spontaneously. The way we diagnose it is with the technetium scan. If you look at the picture here on the right-hand side, we've got a technetium labeled isotope that goes and looks for gastric mucosa. So you'll see the stomach on the scan is lighting up on top. It's secreted in the urine, that's why the bladder is lighting up, and then that little blob there shows us where the Meckel's is. And the treatment for this then is surgery. We resect it. Here's just a diagram of what it can do. Like we said earlier, it can cause an interception. It can twist around the band that's there. It can cause a volvulus. There are many problems, but often the kids would present either with acute abdominal pain or with signs of obstruction. Okay. Pyloric stenosis, again, this is a topic that can be discussed on its own. They present later, about 2 to 6 weeks of life, with projectile vomiting. If you're lucky, you can palpate the mass, but you can't always if they're awake and screaming. The golden standard for diagnosis would be the ultrasound. If you still doubt, you do an upper GI contrast study. Here on the ultrasound, you can clearly see it's a thickened wall. The pylorus is thickened on both sides. We look at the length of the canal. This is not a surgical emergency, it's a medical emergency. So you need to correct the hydration, you need to give them enough fluids, and you have to be aware that they can have a hypochloremic metabolic alkalosis. And that has to be corrected before we do the procedure. This picture is just to show you the hypertrophic pylorus. We do not do this incision anymore, the upper abdominal incision. We make a small incision around the umbilicus, or we do it laparoscopic. But it's a very simple procedure. We literally split the muscle, and then we take a mosquito and we tear those muscles until we see the mucosa bulging out. And then this is called the Ramstead pylorotomy. The procedure takes maybe 20 minutes, but the preparation of the child beforehand, as well as the anesthesia, can take days and hours to get done. Just a quick picture of a Bartholek. If you take an X-ray and you see bowel inside the chest, remember it's possibly a Bartholek hernia. I just put this picture in of the X-ray so that you can see, but we're not going to discuss this now. Thank you. I think I'm still in time. So I'm sure there might be questions.
Yes, thank you very much, Dr. De Villiers, for a very informative presentation. There are already some questions that I have seen on the chat box. So I don't know if we should go straight into the questions, and then some of those people who want to ask questions, you can still ask. You can raise your hand, then we can unmute your mic so that you are able to raise your question. So here on the chat box, there is Dumisani, who asked if the pneumatic reduction done with a mobile X-ray equipment in theater. I think you did touch on that. Maybe he missed it. You wanted to know that how is the pneumatic reduction done under X-ray or what?
It's under screening, so it's not X-ray really, because X-ray is static pictures. So it's done with continuous screening. So it's done in theatre or wherever in the radiology suite where we can screen.
All right, yes. So maybe let me just check. There's other questions. Another question related to the interception. So there's a question here where Dr. Mawela is asking if this pneumatic reduction can be done. Can medical officers be trained to do this in the district hospital, or is it only it should only be done in the specialized center? What's your comment on that?
I think anybody can be trained to do anything. So like I said before, with a radiologist, we let them do contrast enemas and they reduce it like that. So as long as it's done under screening and you know what you're doing and what you have to look out for if there is a perforation. Usually these kits are bigger. So even if there is a perforation, you should be able to manage that in your center. But the problem comes in if your surgeons aren't willing to operate on a 6 or a 9 months old child. If you have a perforation, then now you need to transfer a child with an intestinal perforation to us, and that might take 6 or 8 hours. So definitely you can do it, and people can be trained to do it. But you just need to know that in case, if there is an emergency, do you have a backup, somebody that can assist you?
Just as a follow-up, Doc, you know, in your presentation, if I was to do a word count of how many times you said on time, so I wonder what's for most of these conditions, whether it's a mal rotation and so on, what timelines are we looking at in terms of surgical intervention for good outcomes? Because it seems like you referred as well to a child referred from Mpumalanga. I don't know whether it was a gastroschisis as well, and you referred to the issue of time as well. So I want to get a sense of what are we looking at. Yeah. So
time, it depends on what you have. So if you look at ischemic time, let's talk now about a malrotation with a volvulus. So it's difficult to put a specific amount of hours on it, but usually about 4 hours. So if you have a threatened limb, let's say with a vascular surgery case, or somebody that had an injury that was cut or shot or something and the artery was shut off, we usually look at it around about 4 hours that we say those are almost like the golden 4 hours. So preferably as soon as possible, within an hour or two, you should do the operation. But with anything that's causing ischemia, a strangulated piece of intestine, an inguinal hernia, or like the volvulus, probably the child needs to be at the surgeon getting a laparotomy within 4 hours. Gastroschisis, if you can manage it correctly from the start, you rehydrate them, you cover the bowel, then you have all the time in the world, because that's basically what we do. We cover the bowel, we rehydrate them, we make sure that everything is nice and loose and there's no constriction. So time is, resuscitation is important, and then you need to be able to recognize those ones that need urgent surgery, and usually the volvulus or the strangulated hernias.
And when you say surgeon, you mean a pediatric surgeon, right? Not necessarily a general surgeon, because I'm thinking of our rural provinces and how a patient would move from a very rural district hospital first, and then maybe to a central hospital where we find Dr. Tekhanang. And then maybe from then, that's when we think of Steve Biko. And I'm not sure about the 4 hours, you know, so I'm trying to think what works best. Yeah.
No, again, anybody can be trained to do anything. I'm not saying that you should be arrogant and say, well, I can do everything. I mean, that's not the case. But a general surgeon should be able to manage an acute emergency in kids, whether it's a neonate or an older child. You can do the basic stuff, you can bring out stomas or whatever the case might be, and we can do the rest, the definitive surgery. If it's an imperforate anus that perforated the child sick, it needs decompression, they can do a laparotomy, they can decompress, they can bring out a stoma, and we can do the anoplasty at a later stage. So people are scared to, firstly for the anesthesia and then for the surgery, because the kids are small. But I think if it's really an emergency, you have to decide, okay, if we send this child, he's probably going to die because it's going to take too long. And if you can manage it at your center, that is definitely ideal.
Yes, Dr. De Villiers. So while you're on that point that Dr. Mawela raised about time to referral, there are other questions. There's this is Prudence as well, who also raised a comment. I'm not sure if it's a comment or a question related to time as well. But she's bringing up more political issues about trying to refer a child early, and then there's issues about waiting for a bed, unavailable ICU, and all of that. So I don't know if there's anyone in the platform who would want to comment on how we can try and curb or deal with such problems. Because it happens frequently that there is a patient who needs to be referred, but then there's bed issues and no ICU and that kind of problem. And then
I think from our side, it's important that there are trained pediatric surgeons available closer than Pretoria to Tonga Hospital, for example.
Yeah.
And because now we are getting everybody from everywhere and we have limited capacity. We can just take, if there's not a bed, there's not a bed. And then a child is not transferred, they can't get a bed at any hospital in the major centers, and which is not a good thing. So as soon as people are trained and they start going back into the smaller hospitals, this problem definitely would not be as prevalent as it is at the moment.
Yeah, no, I think I agree with you on that. And maybe just something Prudence also wanted clarity on the fluid management. So she asked, what is she saying? I don't know if I misunderstood. So we start them on 150 mils per kilo per day from the first day, or do we still build up using the usual protocol according to weight and replace the losses? She just wants clarity on that.
Okay, so this is just specifically for gastric schisis. We started at 150 moles. So then you don't really have to worry too much about replacing losses, because you don't actually know what the losses are, because it's just evaporating from the exposed intestine. So that is, we start them on 150 mils per day. We don't go up or down or anything like that. That's the standard, where you would have done 150 on day 3 or 4 in a healthy, normal neonate.
Yeah. Okay, all right. There's many messages appreciating the presentation. Many people say it was very informative. They've learned a lot from it. I'm not sure. Okay, let me say there's another question here from Nonhlanhla. She's saying, with gastroschisis, what's your take with giving several boluses, because some surgeons prefer them, and as pediatricians we don't prefer them because of the risk of IVH, because these are premature children. So what's your take on that?
Well, the bolus, really, you're not going to just give boluses for the sake of giving a bolus. So you give a bolus if you think you're not keeping up with the losses. And like I said, we can't measure the losses that are there. So we need to make sure the child gets enough fluid. So you won't just bolus, because then they're just going to blow up. You will base it on the normal criteria. What's the urine output? Is the urine output adequate? Is the blood pressure adequate? Is the hypertension maybe now from sepsis that's developing, or is it because the child's still hypovolemic, or do they need blood? So you look at those normal criteria when you decide you want to give extra boluses. But then you know, at least with 150 mils per kg per day, you're probably covering most of the losses that you have. And then you can go in those parameters and see whether you need to give extra boluses. But these kids become edematous, so that's a very good point. You don't just give a bolus for the sake of giving a bolus. You need to base it on specific endpoints that you want to reach. And that would be like for any normal neonate when you give fluid boluses.
There's another question from Dr. Ngolela. He's asking about, I'll read it as is Dolicho megacolon more frequent in pediatrics, and at which age do we usually correct it? I'm not sure if I'm reading it correctly.
I have no idea what dolicho megacolon is. I'm sorry, I haven't encountered it.
Yeah, Dr. Golela, maybe you need to clarify your question about a megacolon. Dolicho, I'm not sure as well what that is. And then there's a question about referral. You've mentioned fluid resuscitation and also the importance of covering as needed, and then alleviating any strangulations. There's a question about antibiotics. Do we need to start or not? And then what's the recommendation in terms of specific antibiotics?
Okay, so we start them on the gastroschisis. Well, assume we're talking about gastroschisis. We start them on ampicillin and amikacin. If you're worried about the urine output, you can maybe leave the amikacin, but at least it's not as nephrotoxic, definitely not vancomycin. So ampicillin, amikacin. Our protocol is as soon as they arrive, we start them on those antibiotics. We take a blood culture on arrival. Then after 5 days, we repeat the blood culture again. Then we either stop our antibiotics or we might escalate if needed. But just normal ampi and amikacin to start off with.
Great stuff. Great stuff. Dr. Machete, any other questions or comments that you are looking at?
Yes, there is a comment from Kalemani Muiba. So she's commenting, she's saying, thank you for the presentation, but unfortunately the referral system is failing us and the babies. And she's saying the baby with gastroschisis that you were referring to who demised was from their hospital in Evander, a district hospital. And she says they did all that they could, but the patient couldn't reach Steve Biko in time. And she agrees that really Mpumalanga needs to do something so that we have a pediatric surgeon in the province. So that's the comment from a doctor from Evander. There is also another.
You can unfortunately, sorry, doctor. You can unfortunately just you can just do what you can with what you have at that specific moment. You can't do more if you either don't know what to do or if you don't have the equipment to do it. So we do the best we can under the circumstances in the situation that we're at. So it's extremely unfair for us in Steve Biko to criticize anybody or any child that comes to us or the management, because we're not in your situation. We're not sitting out there that you might not even have something to cover the bowel with. So you do the best you can under the circumstances. I think that is the main thing until you have a better solution.
All right. I think there's just one last question from Dr. Nisi. He is asking, what can they do in the level 1 and level 2 hospitals for kids with intestinal atresia while they're waiting for the patient to be accepted in the tertiary hospital? I think you did touch on this. So his specific question is, should they give enteral feeds or should they put the patient on NG drainage and parenteral feeds?
Yeah, so NG drainage, definitely. The kids with the atresias can last quite long. I mean, sometimes we get them when they're almost 30 days old, sometimes even 40 days. So preferably IV fluids, definitely. And if you have TPN available, you can start that. If you're able to do PICC lines in your center, that would be absolutely great, because a PICC line depends on whether you can put up a drip or not. And then it's just a case of being taught how to thread it in, and you can give TPN through that. So if you have TPN available, definitely, but if you're going to give it through a peripheral line, you just need to make sure that you check your drip sites regularly. And then, so it's mainly NG tube drainage, it's on continuous drainage. We don't give enteral feeds for the atresias, and we put them on TPN or fluids, at least fluids. And that
okay, all right. Yes, okay, no, maybe just one last question from Dr. Terblanche. He's a surgical reg in Livingston. He is asking about the preferred surgical incision. What's your comment? He's asking whether midline or transverse. because they do deal with ped surgery emergencies. What's the preferred incision for?
I'm smiling because even at our center we differ. I prefer a transverse upper abdominal incision. It depends on how old the baby is. So remember, with a neonate, the bladder is an intra-abdominal organ sometimes until a couple of months of age. So if you're going to do a midline incision, you can easily cut into the bladder. You don't have a lot of space to go below the umbilicus is sitting here. You can't go far below the umbilicus because the bladder is sitting there. That makes a transverse oblique incision just so much better because you have more access to the whole baby. It is not wrong to do a midline incision. People do it, but just be aware of the bladder in the neonates that it's sitting quite high up and even up to the level of the umbilicus.
All right. Yeah, I think it's 5 minutes before 7. I don't know if I'm shutting anyone out who still has more comments or more questions. Anyone in the platform who would like to make a comment is welcome to make a comment. But yeah, on our side, thank you very much, Dr. De Villiers, for taking your time to share knowledge, to educate us about these very important topics. Hopefully, in the future, we'll continue to have more informative discussions. We really appreciate that. Dr. Mawela, I'm not sure if there's anything that you'd like to say, a comment.
Yes, just to appreciate this great educational session. I'm not involved in surgery, but yeah, you know, the way you teach and you have made it so simple. But importantly, I thought it was very practical because I think for every condition, you made an effort to really mention some of the immediate interventions, you know, that can be done, and particularly in low resource settings. So I really appreciate that a lot, Dr. De Villiers. I think colleagues would also appreciate that. And we look forward, you know, to this great initiative and partnership. I think we need you to come back and deal with some of the topics, you know, in detail, whether it's constipation or the appendix. I don't know, my tongue is getting all tight. Yeah, you know, so just to really appreciate everything, Dr. Machete as well for leading this and really, you know, championing this initiative. I'm looking at the feedback from colleagues, you know, in a rural setting, virtual learning really is meant to enhance access to this educational platform. So really, thank you very much. We appreciate it. Colleagues, before we knock off, just some quick updates in terms of the next seminar in surgery. We are going to look at anal squamous cell carcinoma, and we are going to have Dr. Machete convening a session where Dr. Kupani Tsenolo would then be taking us through this particular topic. In the next 2 days, we have the HIV master classes are continuing. We'll be looking at the resistance, and I think we have a number of sessions building up to patients failing who need second and third line ART regimens. On the 7th, we are back with obstetrics looking at the preeclampsia, and we have Prof. Mfundo Mabenge, who is one of the heads of ONG at WUSU, Walter Sisulu University. So we look forward to this great educational programs, and we hope that you will join us in furthering your professional development. So thank you very much. We really appreciate it. And then see you next time. Thank you. God bless you. Bye.
Thank you. Goodbye, everyone. Thank you for attending.